All right, good afternoon, everyone. Thank you for joining us today. I'm just going to give a few more minutes for everyone to join the session. So we'll just begin in a few minutes here. And thank you for participating today.
So, Lynn, this is Dave. And again, welcome everybody for joining. Thank you for joining. Do you want folks to ask questions throughout the meeting, or how would you like to proceed?
Yeah, I think I want this to be as engaging as possible. This is sort of, a thank you for everyone that is participating directly. So,
Okay.
to that effect, please feel free to go ahead, and if you feel comfortable unmuting your mics and asking verbally, go right ahead. Please feel free to interrupt. I want everyone here to get the most they can out of this. If you don't want to ask publicly, or maybe if it's not a good time to, please feel free to either type it in the chat or Q&A. My colleagues on the line here, Dave, Denny, Katie, can all help out with fielding questions, and I'll try to keep an eye on everything as well. So,
and I'm going to just jump in, Lynn. Hi, everyone. I'm Katie. I'm with MHDC, and I would just recommend putting your questions in the Q&A, because then everybody can see the questions. In the chat, there will not be. It only comes to the hosts. So other people may have the same questions as you, and so in the Q&A you can upload that question or
and everyone will be able to see
add to it. Yeah, I just made that change. So I would just prefer the questions go there for everyone.
Perfect.
So great.
Okay. Awesome. Thanks.
All right.
Okay,
well,
Lynn,
in the interest of time, I was just gonna say let's fire away in the interest of time. So good afternoon, everyone. And I think it's still afternoon in Arizona time, if I remember correctly. So good afternoon. For any on the West Coast, good morning. Thank you for joining us today. Today, we're going to dive into health system value with a strong focus on the Lown Institute data. We've recently partnered with them in the past year to bring this new data set to the mass community and beyond for anyone that would like to use this analytics tool. So, but before that, let me go ahead and give a quick background about Spotlight, what it is, etc. Some of you may be familiar, some of you may not. So if you have any questions, I'll point you in the right direction to ask us either after or to our website. But first, I'd like to point out our partnerships here. Our partnerships with HBI. So Spotlight Analytics is powered by HBI Solutions. They are the engine that makes it run, so to speak. They are sort of our left and right hands, respectively, to keep Spotlight Analytics up and running as it should be. And as you briefly heard me mention the Lown Institute, they are a local nonprofit bipartisan organization right here in Massachusetts. Some of you may know them and may have even worked with them or have seen some of their press releases or highlights in the local media. And then there'll be a special bonus for those of you. So stay tuned till the very end as we are announcing our partnership with Health Data Viz. They have helped us and are in the process of a project that we're working on to bring better usability to the Spotlight interface. So stay tuned for that. Now, here's a brief agenda what we're going to go through today. So here's the flight plan. We're going to first stop at what is it do, how does it work, what problems does it solve, why you may want to use it, and how do you use it? Is this something that is going to be simple? Can anybody use this? Possibly. So we'll get into that and see if this is a good fit for your organization. And of course, we always have great customer service. We do sort of the white glove service. If you need help with anything particular, we are more than happy to help you, because our goal is to get the community the best data that exists out there that we can at least get our hands on for the moment and improve upon healthcare, right? And then I'll have to sign up. We'll tell you how quick and easy that is to sign up. I don't want this to sound like a sales pitch, but really, I'll get into it, but it is a lot easier than trying to do this yourself. Tell a little bit about the Lown Institute and the hospital index, which is what we're going to be focusing on. And then we'll go right into the Spotlight platform. And then as a reminder, don't forget the little tidbit at the very end, you'll get an exclusive sneak peek at the work we're doing with Health Data Viz. So stay tuned for that at the very end. What is Spotlight? So Spotlight is an analytics tool. It's all online, web-based, so you can access it anywhere. It's comprehensive, it's secure. We have HIPAA and privacy focus, security focused orientation around it, considering that it is hospital data, it's healthcare data, but we try to make this as easy as possible for the users. It is a very robust tool. It sits on top of the Tableau interface. So if some of you may be familiar with Tableau, or maybe not, you'll recognize instantly the view you'll see. But this is designed for healthcare, strategic and analysts and business partners alike that just want to get a better sense of the data that exists that's out there. Now, I will say this isn't everything. I don't think anyone out there has such a thing. And if anyone does, please drop that in the question and Q&A below, because we would love to get our hands on that as well, as I'm sure everyone would. But it just simply doesn't exist yet. We're not there. So in an effort towards that, this is one step closer by trying to put the data in the user's hands in order to get better insights, see their performance, comparative analysis, and just see any variances that may be from within organization to surrounding market share. So right now we have Massachusetts and Rhode Island hospital case mix data. Case mix just naturally being previous year and beyond, because that is just the reporting interval. So until we get better at that, that is just the historical nature of the data. And then we also have, you may be familiar with this now, but there are some Z codes that have an emphasis on social and economic, as well as health equity. So, yeah. Also to note that this platform, so you're in addition to what I said, you're able to essentially get, view the different demographics, cross-analyze that by any number of filters or attributes, such as length of stay, discharge, DRGs, any ICD-10 or procedure codes that you can think of, pair codes, etc. There is a whole host of elements in there. So hopefully that wasn't too lengthy, but if you have any questions about that, please feel free to drop any questions in the Q&A or unmute yourself. And then continuation with that, we have the Lown Institute. So what does this data comprise of that's a little different? Well, the Hospital Institute, the Lown Institute has the hospital index, which does a ranking of sorts, a very comprehensive ranking on some key pillars, being equity, value outcomes, and then, well, I should say it's actually equity, value, and outcomes. So those are the quality measures. Those are the three key pillars. And I'll show you a little chart about that in a few slides later, that you can kind of get a real idea of how this data is structured and then how it goes into sub-levels and drills down further and further. I won't go into this in too detail, but you can find more information on the Lown Institute on their website, as well as specifically the Lown Hospital Index. I will note that this is a great tool. The website is free to use. It has some high-level data, so if that's applicable to you, great. I encourage all folks to take a look at it and use it, as best you can and get as most out of it. However, we do have more of that data and drills into an even further tier that gives you a little bit more of a better view of the whole picture, so to speak. So what problem does this solve? Well, a lot of strategic planners need to do their annual reporting. They need to figure out their operational awareness. Maybe they need to do their community benefits analysis or reporting yearly, and just essentially planning how for the future, how their organization stacks up, and what types of measures or steps they need to do in order to improve. So you sort of need to know where you stand in order to do that. And also you need to know what kind of volume, what have you've been performing, what are some of the higher volume encounters that your hospital or another hospital for that matter is taking on. So that's why it would be useful. Of course, I can expand on this, and I'm sure you have your own use cases. It's sort of kind of, your mileage will vary. So however you see best fit, however you need this to work for you, it's very flexible. There's a wealth of data in here. And I've kind of touched upon this a little bit, how it's used. It's web-based, simple login, Tableau interface. So essentially you can, with this day and age, you don't need to have access set up and kind of pre-limited defined to your workstation in the office. And now that, half the workforce is either remote or hybrid, you can essentially log in anywhere, assuming you have safe measures in place. I mean, maybe the coffee shops might not be the best place to do this with your screen exposed, but to each their own. So I wouldn't encourage that per se, but in your home office, what have you. It's a very simple interface. If you are familiar with Tableau, it may take a little orientation to kind of get used to when you first get up and running. It can look intimidating, but that's what we're here for. We'll kind of walk you through the basics and sort of give you a crash course on how to move things around, how to pluck and pull what you need out of the system. But here's some a few little screen grabs, little tidbits that I plucked and pulled from the system here. So you can see on the left-hand side, there is a drop down of, this is the case mix data, by the way, just as a demonstration of Spotlight in itself. You can see that there are some various attributes that you can just pull down there, maybe zip code, hospitals, or hospital systems. You can, use any of these to filter your criteria as needed. And that's also where the measures will be. We have pre-built measures, so you can easily drag and drop those into your report, and it'll calculate those findings, those numbers right into the report for you. So I find that a very useful feature, especially if it's something you're commonly doing again and again. And then also here in the middle, drag and drop, you literally will pick up, say, the last blue bubble there, data source, and that's just which state you're working with the data source, whether it's Rhode Island, Massachusetts. We also have other states in the works that we hope to come in the near future. But you essentially pick any of those bubbles and drag and drop into whether you want to be displayed in a column or row to get your layout organization of your report. And then lastly, on the right-hand side here, that is the filter side or sort of your criteria after you've selected them. So you can go through and it's as easy as just checking, unchecking what you want to. So for here example, let's see, we have the encounter type I would want to filter by is any emergency department data encounters. And then we are looking at specifically what looks to be Children's Hospital, Boston Medical Center, Cambridge Health Alliance, and Lady Health. So I'm kind of self-explanatory there, but just want to give folks a quick view of that. And oh, yep, thanks, Janice. Anybody have any questions, please feel free to drop them in anytime. Okay? I want this to be engaging and interactive. You took the time to be here today, so thank you. Please feel free. It's a small, intimate group, so please feel free to chime in if you'd like. So in part, what other problems it solves, I briefly kind of touched on it. We have this sitting behind AWS cloud servers. The data is aggregated, so no one ever truly accesses the data in itself. It is always essentially behind closed doors, locked and secure. What you're seeing is essentially a called upon view of the data pieces assembled as you would like them. So it's very compliant. Needless to say, this is a long-winded way of saying it's very compliant, it's very secure, it has privacy focused in mind. And then also just to note, any cells or any volume encounters that are less than 11 are suppressed. Yeah. Any questions with that so far? Okay. Now, how do I sign up? So signing up is actually really easy. You don't have to go through the legal complexity, going through state and government approvals, applications, because if you've ever gone through one, you know how lengthy and just time-sucking one can be. So what we like to do is have a simple end user license agreement that has all the necessary clauses in there to be secure and safe and proper. And then essentially once you sign up, then we can go ahead and create an account and activate you essentially as soon as later on that day, depending on tickets and workload. So it's very quick to get access to it. So if you need something quick and easy, this is probably something you should consider. We also do offer membership discounts. Won't get into necessarily the pricing, but I'm sure some of you have that in the back of your mind. Well, this might sound all great and well, Lynn, but how is this going to cost me an arm and a leg? What's the situation with that? Well, if you want to become a member of MHDC and be a valued member of the data community, and have your voice heard, there's membership discounts for that. We do our pricing on a fair and sliding scale based on net revenue. We want to be very reasonable and keep the level playing field for small institutions to some of the big behemoths. Questions so far? Yeah. All right, we will continue then. All right, let me do a quick time check. All right, so let's talk a little bit about the Lown Institute. The Lown Institute is named after Dr. Bernard Lown in his honor for the excellence of his work that he has done over the years. As mentioned, it's a local nonprofit. It's based right in Brookline, I believe. Brookline near Fenway, Longwood area, if I'm not mistaken. But so it's a local, hometown organization. But what they are is they are a bipartisan, neutral party really that looks at the healthcare industry and wants to bring accountability to some of the organizations that are in healthcare. What they want to do is shine light onto how healthcare is being used, beneficially or not. And what they've done is using complex algorithms to create this hospital index that essentially ranks the whole country on any hospitals that they have reports on, to rank them fairly, but unbiased across the board on various measures, stemming from equity. So these are the three pillars: equity, value, and outcomes, overall outcomes. And then within each branch, you have it drills down into more of these kind of high arching topics. So for today, we'll talk about the value side, but this sort of gives you an idea of what's their focus here. They essentially are advocating for the patient, and in the work that they do, they use this to rank so that the hospitals or the organizations, the health organizations, sort of know where they stand, how well they're doing comparative to others, what could be improved on, and what they're excelling at. So I will say that I believe quite a few of the Massachusetts hospitals are in the top 10. So we do look pretty good for healthcare in that regard. Questions so far? Okay. All right, Dave, feel free, or Denny, Dave, anyone feel free
You're
to
doing a
chime
great
in.
job. No, you're
yeah.
covering it very well, Lynn. I was just going to point out the tier 4 level, which you're already going to do here. So
Yep.
leave that to you.
Sounds good. All right. Next on the flight plan here,
Right.
we are going to talk about some of their tiers. So as mentioned, you have the very high level tiers on the Lown website. So again, I encourage all of you to go out there and take a look and just to even see where you may find yourself in some of the rankings. So some of it may surprise you, some of it may not, for better or for worse. So please, go ahead and check that out. We have the lower tier, the tier 4, that drives down into a much more granular, detailed view to give you a better sense of these measures, whether it's for the purpose of self-evaluation, comparative to others, market share. There are a number of use cases. So, as to use cases, I'll leave that to the users on the call, because each have a different agenda of their own. Right? But here is just a high level snapshot of the 3 different pillars. So as mentioned, we have all the way down to tier 4. And today we are going to talk about the value pillar branch. I don't know if they want me to say pillar, but I just see these kind of as the 3 pillars. So I'm sure somebody will probably correct me once this recording goes live. But avoiding overuse. So overuse, I'm sure most of you are familiar, but essentially it's classified as the low value care for the medical services that may or may not be helpful. They may be controversial at times, most of the time, sometimes, or just ones that often get used too abundantly when it's unnecessary. And we can kind of go into some of those and maybe pick and choose some examples to look at. So that's kind of one side of things, how well you're ranking, you're doing comparatively to others on overuse for certain, some of the common ones, the common categories. And then the other side of things are the cost efficiency. So this is the metric or the ratio of how this compares to their counterpart Medicare costs. So how well are they doing in spending for some of these things? Before I go on, any questions about this?
No, I'll just point out, Lynn, that there's multiple calculations and measures that go into these. As Lynn was pointing out, the algorithms that the Lown Institute uses are fairly complex. I mean, we have descriptions of the measures, and we'll probably see a little bit of that as we look into the demo. But there's obviously a lot of detail that goes into calculating and coming up with these measures.
Yep, indeed. Yep. There's AI for you at work. There is a lot of algorithms that the Lown Institute has worked on and are actually, I'd like to point out that they are continuously sampling, validating, and trying to improve upon it as they're getting more and more data. So, we're looking forward to this next batch of data that should be coming out later this year. So, with that, hopefully come more improvements. But right to your point, Dave, it's a very complex algorithm that they've gone ahead and built and figured out. So if you want to learn more about that, they do have a white paper on their website that tells a bit about the methodology, how their sampling works, their validating of the data, etc. So clearly a lot of work has gone into this.
A lot of data science here.
Yeah, a lot of data science. So that's sort of the takeaway from this.
Right.
You can trust this data. And then just to kind of give you an example of what you're going to be looking at. So here's the part where I'm trying to orient you a little bit better. So the Lown data, the definitions, there are 3 main categories of rankings. The most common one is going to be literally the number ranking that I'm sure you're probably used to, right? So number 1 being the best, you're ranked 1 in the country. That's great. Oh, and I should mention that for our purposes today, we're going to be looking at the ranking. The number you see is solely just in the state of Massachusetts. So just to clarify that. But you're looking at the ranking essentially from 1 to 55 out of the 55 reported hospital or healthcare organizations. So for instance, on the screen here, you see Bay State Franklin Medical Center. it has an equity ranking of 10. So it's 10 in the state of Massachusetts. So that's
Not
pretty
bad.
good there. And
Yeah.
considering that's 55 hospitals, that's a lot of competition. As you know, hospital healthcare is a little cutthroat. So and I'm trying to put that a little nicely, but another example you'll see is a grading system. So grades A to D, there are no E's and F's, but the grade A to D, A being the best. So you'll see overuse grade, as you can see here, B, B, and then the last one, A. Yeah, just something to point out. And then another one that may be odd at first is a star rating. So this comes from, I believe, Medicare, Medicaid, CMS. So some of them use a star rating system for certain aspect measures. So it's essentially 1 to 5 stars, 5-star being the best, as most of us are probably used to on reviews on, Amazon 5-star review, etc. So kind of self-explanatory. Beverly Hospital Corporation has a 4 for EEG for Syncope. So yeah, that's up there. That's pretty good. Yeah. So they're probably not
And that's, that particular measure, just to jump in on that, Lynn, for the clinically oriented people on the call that are interested, that is just one of the value measures. So EEGs for syncope is one of those classified as overuse, or, is it a necessary procedure for diagnosing or evaluating syncope? Syncope is essentially when you pass out, you black out, is what syncope means. So what they're getting is an A rating on that particular clinical use within the facility of Beverly Hospital. So that gives folks a chance to then go and dive in and see what the general practice is at the facility or the organization around the ordering of those procedures for that particular diagnosis or that particular process. So that's how that works. It's just an example of one of the many measures that are in the value.
All right. Perfect. Yeah, it's probably not good to do that for everything. To get a scan for every little thing.
Yeah.
So just to check on time here, let me quickly go through this. I'm not going to read this. I'm sure folks can by now probably gather the sense. So here's your higher levels, tier 2, tier 3. As we go down deeper into the certain measures here. So here we go, going into tier 4. So some of these, sort of like what Dave mentioned there, or PCI. For example, do hospitals, how are they treating this? Are they going and putting in stints every chance they get, even though it may or may not be necessary? That's something to look at here. So, right, or EEG for a headache. Are they doing that for every time someone comes in and goes, I have a headache? Great, let's go ahead and scan you. I don't know. So, some of these are here to give you a better snapshot of how other institutions, other hospitals are dealing with it and how they rank. So it's just something to do a little self-evaluation and comparative analysis. So. All right, let me go ahead and just kind of as we get a little closer to the demo here. I know we got to keep an eye on time. Here's a screenshot. We'll get into the actual demo in a second, but just for spooling up purposes, and it is just to remind folks, it is a large set of data there. So this is not going to be like pulling up a web browser on your iPhone and everything is lightning fast. Not to say that it's slow by any means, but I wanted to show you. Here's the home page. You'll see this, simple layout, simple but useful layout. There's the case mix custom reporting. That's sort of the most popular and most powerful tool. And then we'll go into the Lown side, which here is the summary view. You can take a look. It's just a very high level of everything. And we have what we like to go from kind of the preset views, which are, here's an example, one summary. You can see here, I don't know if you can see my mouse, but the different tabs, if you will, within this. So, when we go and I can click equity and bring up just the equity focus, high level ranks, and then you have here on the side sort of your quick shortcut drop downs. So that is sort of on the left hand side of your built, simplified, easier to navigate views. And then you can go all the way to sort of the pro side on the right hand side, which I'll get into, which is going to be the custom dashboard. So here's the classic Tableau interface. This is going to be the more pro approach, where you can literally anything. When we go into this, you'll see you can have the drop down, as mentioned. Go ahead, pluck and pull those, drag and drop them into your spreadsheet, however you like to assemble, even in the positioning, whether you want your report hierarchy to go to hospital name to or maybe you want to go from city hospital name to certain ranks, certain measures for value. Yeah. And then let me go ahead and stop sharing, and we will go into the demo part. In the meantime, anyone have any questions while I get this?
Yeah, while Lynn's bringing that up, if anybody does have any questions, now would be a good time to jump in. Also, Lynn, we can see your mouse as you're presenting, so that is helpful when you scroll around with your mouse and point to various parts of the screen, because there's a lot of data on the screen. It's a fairly dense presentation of the data, so it's very helpful to follow along with the mouse.
All right, bear with me. I am pulling it up in the background here, and then let me go ahead and share my screen. All right, hopefully you can see this. Yeah.
Yes.
Great. Okay, so this is the actual, demo version of this. So as mentioned, this is the Lown data set here. So we start off in the summary view, which has essentially your main grades here, and then also the rankings here. So you can sort this, you can drag and drop and sort this how you'd like. If you want to see, who is ranking one, the top or the bottom here, etc. You can see your hospitals, systems, as well as some of the single hospital centers or sites. You will notice that for some there is a null. That just means we don't have any data on this for that particular one. So if the overall composite grade isn't there, it's because this is lacking in these two areas. So thus we can't give a full grade, or Lown can't, I should say. So that's here. And then as mentioned, you have kind of your quick shortcut drop down. So let's say I don't want to look at all, but I'm interested in just because they happen to be next to each other, I'll pick these three just to kind of see where they stack up against each other. Now, these are just randomly picked, so don't sue me for this. But as you can see, there is a wide variety or wide variance, I should say, between them, between equity and going on to specifically value here. So the main Leahy Hospital in Burlington is getting a 1. So they essentially are ranking the best in value in the state of Massachusetts. So that's pretty good. It will show you other things like in comparative, just because it stands out so blatantly here. They don't quite exactly rank high in the equity side of things. So, but that's for another time.
So if that were the case, then Lynn, obviously what folks could do is they could then drill in on the equity measures, and we'll look at that later as we get a little more that more detail and see where and why those rankings are what they are.
Right. So you could, if this is pertinent to you, then you could drill into equity on high level, or you can go into the custom custom dashboard and really go into some of those detailed measures and to figure out, well, where does this, stack up? Where do I stack up? What am I lacking in compared to others, maybe in my service area, or comparative size of number of beds. So it's a powerful comparative tool. But for today's purposes, so going into the value, as you can see here, so staying with those hospitals that have been selected, I believe, right? Yep. So still staying with those hospitals here, you can kind of get a sense all across the board for some of the more detailed tier 4 criteria topics of where it ranks the value. So let's see here.
And obviously in this data, you can see both the ranking as well as the grades. So you'll see the larger numbers, obviously on the left-hand side, those are the overall rankings, and the grades are obviously the smaller numbers.
So if you rank, exactly. Yep.
Right.
So,
and I think we represent the star. I think we represent the stars also as a number, if I remember.
Correct. Yep. Correct. So here is, so if you hover, you can see what they are. Obviously we've shown otherwise this would run off the page and probably into the next neighborhood here. But you can see here the headache EEG for headache stars. So that's the star rating. So for Anna Jacques Hospital, you can see they have 3-star ratings. So kind of middle of the road, could be better. Not the worst, could be better. But here, however, you have Beth Israel. Which one? The main
Milton, is that?
Let's see.
Or no, that's overall medical center.
I think that's the main one. Yeah, this one's the Milton one. Yep. So this is the main. Well, the one I was hovering was the main one.
Right.
So I won't harp too much about this. You can kind of get a sense of how this tool could be useful in this view. Now let's go into the custom dashboard. This is sort of the full-blown one that we were talking about. So as you can see, you have some of your blue bubbles. So if you want to go ahead and filter, so if I want to go ahead and filter certain hospitals again, so just for keeping things consistent, let's just pick these 3 again. Okay, so out of these 3 hospitals, and they're shown here, I can move these around if I want to. You also have, just to mention here, the HRR, which is the hospital referral region. So at least how this state is divided into the 4, but you also have the Rhode Island one, I believe. So otherwise it would be the New York, Albany, which do I have that right? I may have to double check on the map, but you essentially have, I believe, the 4, which you can kind of geographically imagine, basically almost anything from middle of Massachusetts onward into New York. Albany is one region. And then you have their Springfield is divided in 1, and I believe that kind of crosses over a little bit more east. And then I believe Providence is the southern Mass and into the Providence region. So
yeah, I think HRR is hospital referral region or hospital referral zone, essentially. It's kind of like a geographic grouping. We have a map view too that we could show that kind of lays that out.
I'll pull
Oh,
it
there
up
you
here.
go. Look at you, Lynn. Very good.
I'll just pull up here so you can get a quick idea here. Just gotta keep an eye on time, but so out of the ones, it's still holding on to the value. So right now it's focusing on just this, but if I were to go ahead and select all, then go ahead, then there you go. You can see here,
Right.
The different
regions.
regions, right? So as mentioned, oh, sorry, I was wrong. This is split up into 2. Once you get over to the farther left, that's where you get into the Albany one.
It's basically Berkshire County plus Albany, because Albany is a part of that service area.
Yeah, exactly. This sort of 1.5 main centers out there. So all right, so going back to this, and just let me go ahead and just kind of cue it back up for how we were. So let's go into sort of the value measures. So here are the list here, and each of them have their own sets in here. So you can kind of imagine what's possible here: patient safety, outcome, satisfaction, pay equity, inclusivity. Those are all part of the, as you can imagine, the equity branch. But so for example, I don't know, let's see for this one. So if I wanted to go ahead and pop that measure in here, go ahead, then now you can see how they rank in this specific category. So, is it necessary? Is this necessary? Can they, have alternative interventions instead of kind of going into having these surgery? I don't know, maybe physical therapy is an option. Maybe there's some other more beneficial or potentially just as beneficial treatment. So that's kind of what this measure is looking into. So and based on how the hospitals rank in this particular view, you can kind of see where they stack up. So Winchester, Mount Auburn, not great in this particular area field. So something that they can look into and improve upon. Their overall Lown grade is good. So that might be an area of improvement or just something to be mindful of. So more than anything, this tool is powerful in the sense that you can use it just to see where you stand. You can use it to make improvements, adjustments as necessary. So again, the use cases, to each their own. Your mileage, may vary. It's a powerful tool. So however you see fit, there's many use cases which would be endless if I were to kind of go on and rattle them off here. But you kind of get a sense of the power that this tool has. And this is just at the tip of the iceberg. We're going to have more of these meetings, more of these demos. And if anyone's interested, maybe, write that. I guess you can't do it in the chat, but maybe drop us a line, or even just write it in the Q&A that you would like to see the case mix side of things or any other topics. We would love to hear your thoughts on this. So I want to make sure that we're serving the healthcare community as best as we can. Let's see. I want to make sure. Okay. Does anyone have any questions? And this wasn't we didn't have too much time to kind of dive too deep into this, but essentially it would be more of me dragging and dropping, kind of telling you what it is and shifting the ranks around. So that you can kind of get an idea of how you would do things.
Yeah, just for a use case real quickly, Lynn, and I know we want to give time for the special preview here in a minute. And introduce Kathy.
Which I'm excited as well. So
yeah, I want to introduce Kathy and her team. You can imagine a quality program or something of that nature where these types of measures are tracked over time. And if there's focus, it's a hot topic. And then certainly with equity and outcomes, and particularly equity in today's world, and that's what we'll be talking about here in a minute, is a little deeper look at equity. That's becoming more and more a part of incentive programs for facilities to perform on equity and perform on quality measures and outcomes and that sort of thing. So you could sort of see how a program could be structured around some of these measures, and then these views could be used over and over again. Custom views could be created. The data can be downloaded. It can be put into a more fancy view, if you will. But obviously, we're working with Health Data Viz on improving and adding to some of the ways that data is visualized in this tool. So we'll get a feeling for that in the preview that's coming up here in just a second. But just wanted to see if anybody had any questions on what Lynn's presented before we do that. Assuming you're done.
Yeah.
Okay.
Unless anyone has any specific questions.
Okay.
Hearing none.
Yeah. You want to introduce Kathy?
Sure, okay. Sorry, Kathy. There's not much to see on the screen, but sort of says it all.
What more do you need to know?
Yeah, exactly. Some of you may have worked with Health Data Viz, and if you have, then you're one of the lucky few like us that know their work. And some of you may have already seen their work and just don't even know it. That's how great their stuff is. You don't even know that it's happening. Right. So
yeah. So Kathy, I'm trying to. Wow, the screen's popping around.
Kathy, yeah.
Kathy Rowell is the president, CEO, Health Data Viz. Is that correct, Kathy? Catherine?
One of the co-founders.
Something
I
like
Don't
believe,
that?
call me
right?
later, late for dinner. Co-founder, principal.
Co-founder. Okay,
Yeah.
whatever. That sounds good. So she will give us just a very quick preview overview of sort of, we're calling this sort of the future view of where we're headed with some of the equity measures that Lynn mentioned at the beginning of the presentation around particularly using the Z code data, which is the SDOH, social determinant of health
Social,
data.
yeah.
Now,
Social economics and yep,
yeah,
exactly.
right,
So
exactly. So given
very
that,
important stuff.
it's very important now. A lot of it does intersect or overlap or correlate. There is correlation with some of the other data, obviously, we have in Spotlight, whether it's case mix data or even just the Lown data that Lynn was just showing us. So, our intention long term is to do more sophisticated data correlations between the different data sets. But at this point, we're just, starting to embark on this sort of equity data journey, if you will. And so Kathy will show us a little preview of what that's potentially going to look like here going forward. And this is work in progress, so we're very happy to take comments, suggestions, or feedback from anyone. So with that, Kathy, I'll turn it over to you.
Cool. Thank you. All right. Can everyone see my screen?
Yes.
Terrific. All right. So this is what we have been engaged by the Mass Health Data Consortium and Spotlight to create. And what I'm going to show you are wireframe prototypes. So there's no actual data on here. And so we have been working through the designs. So I'm going to show you a little bit of the functionality, orient you, and as Dave and Lynn mentioned, these are focused on health equity. So let me just orient you in the beginning. Over here on the left-hand side of the panel, you'll see that we are showing information by all hospital settings, so inpatient, emergency department observation cases. And one of the key things here is that we're looking at your specific hospital or medical center. You'll be able to choose those and then compared to peers or everyone else, because that's a huge value proposition, is to see how you're doing compared to everyone else. And so very quickly, these are placeholders, but you'll be able to see, what are my total number of encounters for the dates I've selected? What's the difference from peers? What's some trends? What's the social vulnerability index for the places where my patients reside that I'm taking care of? How does that compare to my peers? On a scale, maybe my peers are lower and my social vulnerability index is higher. And then you can collapse and expand this panel. Over here, you can also apply filters. So you want to see different dates. You want to see my hospital. I only want to see certain payers, certain age group. Here's who I want to compare myself with. I only want to look at emergency department. I want to look at this through race and ethnicity, or I want to look at this through, age or by sex or patient's preferred language. Coming back over here to the top, you'll be able to see always what filters have been applied to this view. Oops, and I wanted to show one more thing, sorry. Also down below here, here's a key for some of the data, but also you'll be able to download these images. So you want to take it to a meeting, or you want to put it in a slide deck, or you want to send it out in a PDF. So that functionality will be here as well. So you'll always be able to see what, you have applied for a filter and what it is that you're taking a look at. Starting at the top, and I'm just going to talk quickly because I have a few things to share and show with you. Now we're showing in the left-hand column, here is, we selected to show this by race and ethnicity. So we're using our label once and we're saying what, for that category, what percentage of the patients are we seeing in this distribution? This is my patient service area. So you heard Lynn talking about and Dave talking about hospital referral region, but the concept here is proportionally are the patients that I'm taking care of similar to the proportion that they represent in my patient service area. So some sense of proportionality about who you're taking care of as compared to your patient service area and their demographics. How is it different from my peers in terms of, this distribution? What's the social vulnerability index for the folks who are that I am taking care of compared to a peer? How many of these patients have been assigned any Z code? We know these are regulations that are coming down from CMS and the Joint Commission, et cetera. So how well am I doing in capturing those social determinant of health through Z codes, comparatively speaking? Then down below, so this is a little bit about, that population. Then down below, we're showing, all right, how are you doing on assigning Z codes in these big categories? So again, my hospital peer, the difference, and again, stratified by whatever you've selected. Here, it's race and ethnicity. Included is functionality to sort and say, well, I want to see it sorted by what is the biggest, largest number of Z codes coded for that Z code for Hispanics. And then additional functionality over here. This one always gives me a little bit of a fit why it doesn't want to cooperate. Here we go. Here you can also flip from the bar charts to this table that says, how does my coding on these compare to the peers that I'm comparing myself to? Do I have more with these codes in these strata, or do I have fewer with this code in these strata? Moving down, so this is about, the patient population and their social determinants of health. Moving down, the next view is, what conditions are we seeing these folks for? And again, the layout is the same so that you don't have to reorient yourself, and you're able to say something about one condition across, but you're also able to compare these columns between the different conditions that you're seeing, or the different Z codes that you're seeing. And then moving down, how are we doing? So who are we taking care of? What are we taking care of them for? How are we doing? Again, stratified by race and ethnicity here. Some information about their encounters, their readmissions, their mortalities, their average length of stay, and how that's different from peers. And in the future, as we continue to develop this, we imagine being able to click, for example, a condition, and if there are different outcomes of interest for specific, that this would swap up to show what those are. I know we don't have much time left, so I just want to move through. We'll also be creating some views based on outcomes, so specific outcomes of interest, and we'll keep these the same so that you don't have to reorient every single time you come to these views. Let me skip to the third one here and show you a little bit more functionality. So this is the last one, and I'll go quickly. So if you have questions, again, the functionality will be the same. Here, we're showing things a little bit different. We're saying, okay, social determinants of health. We're giving you a little bit of information about, for each one of these categories, how many have I coded? What's the difference from my peers? And then some key information like, okay, for these Z codes, how many ED visits are we seeing on average? What's their average length of stay? How many hospital stays do they have? How many folks are going to the ED, more than 10 times in a month, or whatever, category we determine. And then down below, here are the Z codes. Now we are stratifying by whatever you selected, again, race and ethnicity. And then if I were to choose, for example, that top Z code, it would expand and say, for that Z code, here are the conditions, here's how they stratify, and here's the trend chart of what we've been seeing for these over time. That is a really fast rocket sled tour. There are other things that we are working on and imagining, but the idea is to create these comprehensive views that hopefully are intuitive, show you lots of information, get you thinking, as Lynn and Dave had mentioned, and being able to explore and understand, what is the underlying data that is driving some of the results that you're seeing, displaying the opportunities for you to dig in deeper. So I will stop talking.
Thank you very much, Kathy.
You're
That was a great high-level, very fast overview. And as Kathy pointed out, there's a lot more to be explored here as we continue to work through the details of these views. But we'd love to hear anybody's comments, feedback, or questions about any of the topics we've presented today. And obviously, there's a lot of work in progress here on this side in particular, as these are wireframes, but they're conceptual wireframes that are based on the data sources we have today. We are thinking and looking at potential other sources of external SDOH type data that we may be able to incorporate into these types of views in the future, but we're also very interested in how to potentially begin to correlate both the case mix data, if you think about that in terms of like volume essentially, but really we have volume here as well in Kathy's view, but case mix data, overall views with the Lown data in terms of the equity value and outcomes measures there, combined with social determinants of health. So if you kind of think of the three aims there essentially that we're going for, which is how our volumes or production overall, how many are we seeing? What are the essentially the outcomes of that from a Lown perspective, and then what kind of social determinant factors are weighing into those outcomes and those other sort of global sets of data. So that's the big picture view. We have it in our head, at least that view, but we have obviously a lot of details to work through to get to that point. But we'd be happy to hear any questions, comments, or suggestions from anyone. And you can feel free to, you can either unmute your mic or raise your hand or type a Q&A, anything that you wish to do. Send a carrier pigeon. We're open to it.
Smoke signal. Yeah.
Yeah.
Well, hopefully all this made sense. This is very exciting, and thank you, Kathy, for showing us this. What comes to mind, Dave, is like what you're saying. I think of the word triangulate, right? So it's kind of being able to pinpoint exactly where something is, right? So being able to do that is so powerful. So we're excited to be able to go towards that direction. Like Dave, Kathy said, this is all work in progress, but it's not in the too distant future. I mean, later this year, hopefully sooner than later, this will be up and running in Spotlight, and it will give you essentially a better honed in view of different elements, fields, measures, attributes, what have you, about how you're performing and how others are. So
yeah, I think the comparative,
obviously
the comparative data is very, very important, valuable. A lot of health systems know, particularly, they have their data. They're like, oh, we know how we're doing with that. But then to be able to cross tabulate and compare that with others within your service area, or even just within the state itself, or compared large academic medical to community-based hospitals and facilities, things like that, that really do weigh in. And then obviously this can also be a very powerful negotiating tool during contract times. It can be used for, sort of quality program outcomes, as well as board reports, things of that nature. You can imagine all the different.
We're seeing more and more of that,
use cases. Yeah, right. So we'd be very happy to do a private, discussion, presentation, demo for anyone that's interested in diving in deeper as well. Just feel free to reach out to any of us, Lynn in particular, and we'd be happy to do that for you.
Yeah. So, well.
They can also visit the website, right? You have it up there. Sorry, I was going to say they can schedule a time too with Lynn that way.
Yeah,
perfect.
It's so much easier. Yeah, that way you can skip the emails back and forth. How about Tuesday? No, how about next Tuesday? So yeah, there's a link on there. As technology is getting better, you can just go ahead and it shows my calendar. It will pop up, so you can go ahead and just select if you want to meet, whether it's just us or if you want to have a bigger, larger discussion. Just please feel free to reach out to us. Happy to kind of go ahead and tell you more about this, show you around, and see how this tool can be applicable to your use case.
Great.
Like Dave said too, all of this is complementary to each other. A lot of hospitals and organizations have their own sets of information, but with this, along with others, it's that whole triangulate effect. They are complementary to each other and just enhances that information, right? So exponentially.
Perfect.
All right. I guess with that, we will let you get back onto your day. So thank you for spending the time with us. And this recording link will be sent out, and be on the lookout for more meetings like this. And feel free to reach out to us anytime. All right.
All right. Thanks, Lynn. Thanks,
Everyone.
everybody.
Thank you.